Now that we've done with our review of anatomy and physiology, let's continue with the hearing measurement, and we'll talk more about Puretone audiometry. So here's an outline of what we're going to be doing in this lecture. Briefly, there's going to be an introduction, and then we'll talk about different aspects of Puretone audiometry. Audiology in general is concerned with two kinds of measurement. For the most part, as a clinical audiologist, you're involved with assessing the hearing ability of patients. But you might also be involved in measuring sounds in general. And in some specific positions, you might be that might be a major component of your work. Like as an industrial audiologist, you might be involved in measuring noise levels. As a school-based or as an educational audiologist, you might be measuring noise levels in classrooms or in speech therapy room settings. Environmental sounds are measured with specific calibrated equipment. Well, typically they are sound level meters. So sound level meters are equipped with pressure microphones that measure airborne sounds, and they report to us in terms of dB sound pressure level, or you might uh, prefer to record sounds and other dB scales such as the dBA or C. Sound level meters are also important, are used for audiometric calibrations. As an industrial audiologist, like this gentleman, you might be involved in measuring noise levels from different places in the factory. And based on those measurements, you might be recommending environmental modifications to reduce noise levels. Or you might be recommending types of hearing protectors for workers in that environment, and might be prescribing how many hours they can work per day if the noise cannot be reduced. We might be talking a little bit more about industrial noise and noise-induced hearing loss when we talk about the disorders of the ear. But again, for the majority of an audiologist's time, you would be assessing hearing. And hearing can be impaired due to lesions in the external ear, the middle ear, or the inner ear, or anywhere above the inner ear before it reaches the brain. The main goal of your hearing assessment would be to evaluate whether the hearing is within normal limits, and if it is impaired, or if you do see hearing loss, we would want to quantify how much hearing loss and try to localize where this hearing loss is coming from, or where the damage is in the auditory system. In the present day, in clinical audiology, we have access to a wide array of techniques and equipment to assess the auditory function. Often I tell undergraduate students that a well-equipped audiology clinic is almost like the cockpit of an airplane. I know it's an exaggeration, but present day we have a wide variety of sophisticated equipments that lets us assess different parts of the auditory system. So when you're doing a hearing assessment, it's kind of a multi-stage process. You probably would begin with doing a case history and building a rapport with the patient. Then you would follow that with a physical examination, perhaps using an otoscope. And then there is a battery of tests that you would typically do for a conventional hearing assessment. And The results we obtain from any specific test, we would like to verify that with other tests. And, uh, and this is what we call as a cross-check principle that we've been promoting for a long time and practicing for a long time. Specifically, it came for when we're doing pediatric testing, where we use objective test measures to confirm our behavioral um, uh, results. And now it's considered fundamental for any audiological evaluation that we use a test battery and use this cross-check principle before we diagnose hearing loss. For instance, when we're doing Puretone audiometry, if you see an air-bone gap, a difference between their air conduction and bone conduction thresholds, which probably is because of a conductive hearing loss, we would like to confirm that with doing tympanometry, and we might see an abnormal tympanogram. We also might have observed a retracted eardrum or fluid behind the eardrum. All of this would concur with our diagnosis of a middle ear condition um, and could be because of an ear infection. We had hinted on this earlier when we talked about tympanometry, but broadly, the tests that we use can be divided into subjective or behavioral tests and objective or physiological tests. And then this categorization depends upon how much participation is required from the patient. Puretone audiometry, speech audiometry, the patients are involved and they're required to actively participate by letting us know that they heard tones or repeating words or sentences for us, as is the case for speech audiometry. But we also have other tests such as tympanometry, acoustic reflexes, autoacoustic emissions, and auditory brainstem response testing, where the participation of the patient is minimal. Um, so we need their cooperation, but they do not require to actively respond to sounds. And these are considered objective ways of testing, and they are testing different physiological measures. Um, Puretone audiometry is one of the earliest audiological testing uh, test procedures, and it's still considered the golden standard for hearing assessment. In Puretone audiometry, essentially we compare an individual's hearing threshold to that of established norms. And what we consider threshold is the lowest signal intensity um, where a person identifies 50% of the time for multiple presentations. And the signals that we use to assess the threshold can be presented either through air conduction or bone conduction means, something that we're going to be talking about just a little bit. And the hearing sensitivity that we assess is pretty much the number of decibels above, in some cases below, what we consider an average normal hearing person's threshold for different frequencies. And when we talked about the decibel scale, we talked about how we use the dB hearing level or dBHL scale for clinical audiology. And this average normal hearing person's threshold is 0 dBHL. And Purotones are perfectly suited for us for hearing assessment because they're spectrally simple and we are specifically targeting a certain frequency. These are examples of waveforms of a purotones and a spectrum of a purotone. So you can see that there's not energy in any other frequency, and the reason why they call us purotones. And when we talked about the anatomy of the cochlea, we talked about how tonotopicity is kind of an underlying theme pretty much within the whole auditory system. And it refers to how there's discrete frequency representation within any given structure within the auditory system. So in the case of the cochlea, along the length of the basilar membrane, Frequency is distributed systematically. So moving from high frequencies at the base of the cochlea to low frequencies at the apex. Now, when we use pure tones, we can specifically, we are testing different discrete parts of this cochlea. So in a way, we are sampling one's hearing um, along the different parts of the cochlea. Now, in Puretone audiometry, we can present the stimulus through two different conduction modes, basically air conduction and bone conduction. So the whole hearing pathway of the peripheral auditory system can be divided into two major divisions. We have the conductive um, system and the sensorineural system. In the conductive system, we have the outer and the middle ear. So as you can see over here, the outer and the middle ear. While the sensorineural system would be the sensory part, the inner ear, and the neural part, the auditory nerve. Okay. So if one tests through air conduction, you're testing all those components of the peripheral auditory system, right from the external ear through which the sound has to travel, and then the middle ear before it reaches the inner ear and the auditory nerve. Okay. And that's the typical way that we listen to sounds. The majority of the sounds that we listen in the environment are they travel through the air conduction mode. However, we can also listen to sounds that are presented through the bone conduction mode. When we are listening through the bone conduction mode, um, the sounds actually bypass the external and the middle ear and directly reach the cochlea. So in air conduction, we're using both the conductive and the sensory neural mechanism. So you're assessing the entire, well, specifically the peripheral auditory system. Um, and when we're doing air conduction testing, we'd be able to determine if a person hears within normal limits, and if not, then we would be able to quantify how much of a hearing impairment he has. Okay, in other words, we'll be able to determine the severity or the degree of the hearing loss. Okay. However, when we're doing air conduction, we are measuring only the sensitivity of the hearing apparatus. Um, it doesn't provide us any information about the etiology or the cause of the hearing loss. However, when we're using air conduction along with bone conduction testing, now not only we can determine the severity of the hearing loss, we'd also be able to do a differential diagnosis and determine the type of the hearing loss. Air conduction is typically tested with transducers such as supraoral headphones, typically earphones, or insert earphones, like over here, or you can present air conduction sounds through loudspeakers, like in this instance, where the sounds are actually presented through loudspeakers. And that might be suitable for some populations, especially the pediatrics, who do not tolerate wearing headphones or insert earphones. The problem with using loudspeakers is um, we wouldn't be able to get ear-specific results uh, because the patient is going to respond even if they hear it only through one ear. So typically, it's the better ear, of course, that they'll hear the softest sounds. And so our diagnosis, we wouldn't be able to specify, um, get ear-specific results. And so even if they hear with the normal limits, we would say that they hear with the normal limits in at least the better ear, our one ear. So when you're testing through bone conduction, you're essentially bypassing the conductive system. So namely, you're bypassing the external ear and the middle ear and directly testing the sensory neural system, namely the inner ear and the auditory nerve. So bone conduction is a test of the sensory neural function. And typically we test bone conduction using a transducer known as a bone oscillator or a bone vibrator. And we do so by placing this bone vibrator on a person's mastoid. One thing you need to remember is when you're testing bone conduction, both the cochlea are being stimulated. And so when you're seeing a response, um, it's likely the response from the better cochlea, the cochlea that has um, lower thresholds. So here is an illustration of how a bone vibrator is placed on the mastoid of this patient. And as you can see over here, bone conduction vibration actually directly stimulates the cochlea, so bypassing the external ear and the middle ear. And when you're presenting through bone conduction, almost all the sound you give in one side transmits to the other side, so both the cochlea are hearing the sound. Either or both of them can respond. So the patient will respond if he hears in one or both the cochlea. Now, if you test through air conduction and bone conduction, um, as I said, we'll be able to determine the type of the hearing loss. Because in bone conduction, we're bypassing the external ear and middle ear. So in patients who have a condition that affects their external ear and the middle ear, you might see poorer air conduction threshold. However, when we were to do bone conduction testing, they might hear things within normal limits. So when you compare your air conduction results with your bone conduction results, you'll be able to determine where this hearing loss is coming from. So here's a schematic illustration of air conduction and bone conduction hearing with tuning forks. So when you're using the air conduction pathway, then you go through the conductive pathway and the sensory neural pathway before the person hears a sound. So it has to go through the external ear, the middle ear, the inner ear, and then the hearing nerve or the auditory nerve. But when you're testing through the bone conduction pathway, you're bypassing the external and the middle ear and directly stimulating the cochlea. The René's test is one of the classical tuning fork tests that was used traditionally by otolaryngologists or ENTs, or pediatricians, to assess one's to determine the type of the hearing loss. Here they present the sounds through an air conduction mode, and then they present it through the bone conduction mode, often by striking the tuning fork and placing the base of the tuning fork on the person's mastoid. So when they compare the responses they get for air conduction and bone conduction testing, they'll be able to determine, get an idea of what the type of hearing loss is. Of course, with the advent of Puretone audiometry and, well, just audiologists in general, tuning forks are less commonly used because tuning forks might not be able, might not be considered, might not provide us with accurate results. Because one thing, tuning fork, the sounds that you get from tuning forks are not calibrated, and so the loudness is not calibrated, so you wouldn't be able to assess the degree, the severity of the hearing loss if the person can't hear. And second, often we use, I mean, it was only one tuning fork was used. Like for in this instance, it was a 512 hertz tuning fork, so which assesses only the hearing at that frequency. And so you would miss out hearing losses that are not flat. If they have like a sloping hearing loss, so they might actually be able to hear the 500 hertz, but not be able to hear higher frequencies, which is not assessed. So hearing loss, we have three major types of hearing loss. The sensorineural hearing loss, conductive hearing loss, and mixed hearing loss. So if the sensory neural pathway is disordered, or if there's an abnormality in the cochlea and the hearing nerve, then you're going to see a hearing loss in both air conduction and bone conduction. Okay, so if you were to present sounds through a earphone or a bone vibrator, you will see this hearing loss. Okay, and that's what we call as a sensory neural hearing loss. Okay, if the conductive pathway is abnormal, in other words, if there's a problem in the external ear, something blocking the external ear or a tumor growing in the ear canal, or if there's a problem in the middle ear, like an ear infection or a perforated eardrum, for example, uh, then the hearing loss is going to be seen only through the air conduction pathway. But if you were to present sounds through the bone conduction, since you're bypassing this abnormal external and the middle ear, uh, things might be within normal limits. Okay, so in that case, you have a conductive hearing loss. So if your air conduction thresholds are are abnormal, but if your bone conduction thresholds are within normal limits, then it kind of indirectly tells you that the problem is somewhere in the external ear and or the middle ear, and your diagnosis would be that it's a conductive hearing loss. In some cases, you might see a conductive hearing loss component along with the sensory neural hearing loss. In other words, there's a damage in the outer and the middle ear, along with the damage in the inner ear and the auditory nerve. And that's what we call as a mixed hearing loss. Okay. Some examples of a mixed hearing loss could be chronic middle ear infections that have been untreated for a long time, resulting in affecting the inner ear. So when you were to test them, you'll see that this person has a hearing loss in air conduction, uh, but you'd see that he also has a hearing loss in bone conduction, but not as much as the hearing loss in the air conduction. In other words, air conduction is affected, bone conduction is also affected, but the bone conduction thresholds are lower than the air conduction thresholds. Okay. Something that we call as an air-bone gap. So when you see that, then that would be a mixed hearing loss. Another example of a mixed hearing loss would be an elderly individual who has already an age-related hearing loss, what we call as presbycusis, and is presently suffering with an ear infection. So if you were to test him, you would see that his air conduction thresholds and bone conduction thresholds are affected, but the bone conduction thresholds are better than the air conduction thresholds. In other words, we have a significant air-bone gap. So let's talk about Puretone audiometry. So much an audiometer is but a calibrated electronic instrument that enables us to measure one's hearing sensitivity using puretones that you can vary in terms of frequency and in terms of intensity. Most diagnostic audiometers let you test both air and bone conduction modes. And the puretones that's conventionally used range from 250 to 8,000 hertz in octave steps, namely in doubling of frequencies. So we test 250, 500, 1000, 2000 hertz, 4000 hertz, and 8000 hertz. Some audiometers might have the facility to test high frequencies, um, all the way up to like 20 kilohertz, some specifically known as high frequency audiometry. And that's gaining popularity now because high frequency audiometry has been shown to be more sensitive to subtle hearing losses that we might see with um, in terms of in oncology patients or with ototoxicity or initial stages of noise-induced hearing loss. But conventionally we test up to 8,000 hertz. 250 to 8,000 hertz. One thing you need to be acutely aware of is when we're doing pretty much any behavioral assessment, um, what we obtain is not actually a real measure of one's hearing sensitivity, but it's actually the response, the patient's response for a set of acoustical signals that we give to them and that we interpret as hearing. Okay. So in other words, there's a number of variables that affects our test results, and that's what we're going to be talking about in the next few slides. Okay. So the reliability of any testing we do is going to be based on the interrelationships between these variables, um, which include how well calibrated our equipment is, where we're doing this testing, uh, the patient's participation and performance, and how experienced is the tester. So here are the variables that can potentially affect your Puretone audiometry results. The Puretone audiometer itself, the, the test environment, the patient's role, the clinician's role, and what kind of test procedures we are doing. As I said, diagnostic audiometers enable us to test both air and bone conduction testing. Some screening audiometers or screening portable audiometers might have only the facility to do air conduction testing with headphones. Again, those screening audiometers are used for the screening testing to determine whether this person has got normal hearing or not. And if not, if they fail the screening, then they are referred for a diagnostic Puretone audiometry to accurately quantify and diagnose the type of hearing loss. And in most audiometers, when in the bone conduction testing, the highest level that we can test is typically only about 60 or 70 decibels. While in air conduction testing, we might be able to test all the way up to 110 or 120 decibels. The reason for that limitation when you're doing bone conduction testing is because to vibrate a bone vibrator, you'll need a lot more power, so we might be limited by the power of the audiometer. And then the second reason is that even if we were to test at higher intensities, typically those bone vibrators are going to result in distortion, and so now the tones you're presenting are no longer pure tones, and that's not desirable. So typically the highest we can go is around 70 decibels or so in most audiometers when we're testing bone conduction. One thing you need to make sure is that the equipment that you use is reliable and accurate, and you do so by calibrating the equipment frequently. Pretty much calibration is the process of confirming whether your equipment is producing what it's supposed to. Okay. In earlier days, and even nowadays, when we do everyday checks, we do what we call as biological calibration, where we either listen through headphones and bone vibrators ourselves, or we test another person in the clinic who we know to have normal hearing, just to confirm whether the tones can be heard and whether they sound correct. But annually or in a biannual time, you would also have to do this detailed electroacoustic calibration to make sure that our testing equipment meets some specific standards, national standards. The ones that we follow over here is the American National Standards Institute standards for audiometry calibration. And that testing is more elaborate. We would, would involve a sound level meter and an array of other equipment. Um, and typically, it's done by engineers that we might have to um, um, rely on to do this electroacoustic calibration. Another important variable that affects your test results is the environment where you're doing this testing. Um, for reliable testing, we need to make sure that the test environment meets some ambient sound pressure levels for just ambient noise. Um, and the norms are actually provided again by ANSI. And the actual levels, well, it's going to depend upon the frequency and the type of earphones that we're using. And they can range anywhere from 21 dB SPL to 78 dB SPL. So this is where those sound measurements might fall within the purview of an audiologist in that test environment. So you might have to periodically measure noise levels within the audiometric suite to make sure that you confine those levels confine for the standards. There's three major ways that we can actually reduce or control this ambient noise. Um, you might use specially designed um, earphones. You might test using insert receivers, and you might do those testing in a sound treated chamber or a combination of these three ways. The traditional earphones is what we call a supraoral earphones because they sit over the ears. They come with different sizes and with different cushions. Um, and selecting a earphone depends upon a combination of how efficient the earphones are to reducing the background noise and comfort. Um, you might have more problems using those bulky earphones, even though they are more effective in reducing the noise levels. They might be heavy and might not be tolerated by, for instance, by children. Um, and another important point that you need to remember is that when you're doing the calibration, audiometers are calibrated for that specific headphone. And so if you do find yourself working in a clinic that has a number of audiometers, you need to make sure that just because the earphones look alike doesn't mean that you can switch the earphones. Because initially when they calibrated, it's calibrated for that pair of audiometer and headphones. Insert earphones are a preferred mode of testing for air conduction um, because they're, they're comfortable. Um, they also give us an advantage in getting better ear-specific results. And they are also more sanitary because they're you're using those disposable ear tips that are kind of custom fit for the patient. And here's an illustration of a tip fit on an insert earphone and a patient wearing those insert earphones. The test environment, as I said, plays an important role. Um, a true soundproofing a room is a very expensive endeavor and probably is not required to do reliable audiometric testing. What we typically see is sound treated rooms. Again, the objective of sound treating a room is to kind of, as much as possible, isolating that room from the rest of the building. So that way we are not having any um, body transmitted sounds from the rest of the building. So how we do that is by adapting um, certain aspects of the room, including the floor, carpeting the floor, having noise reverberation reducing tiles perhaps in the ceiling and in the walls. Um, and so your goal is to actually reduce external interferences and reduce also reduce internal reverberations like from footsteps and overall building vibrations. Rooms in which this reverberations um, are markedly reduced are known as anechoic chambers. So building a large anechoic chamber is actually, again, it's a very expensive um, process, um, but you still might find those anechoic chambers, anechoic rooms in some well-funded audiological research institutes. Um, Apparently, NASA has a few anechoic chambers, and many of the hearing aid company research and development groups have these anechoic chambers. Um, some clinics might have these small anechoic chambers specifically to test hearing aids. But again, a large anechoic chamber is you know, rarely needed. It's rarely seen and needed for just clinical audiology. So audiology test rooms might be one or two room suites. Um, so here are examples of one or two room suites. Either in either room settings, lighting is important. You should avoid fluorescent tube lights to avoid that low frequency hum that most of these lights have. Of course, an important factor that affects our test results would be the patient himself. So our approach to the patient should consider their age, their intelligence, their educational background, their motivation for this particular hearing evaluation, and their overall willingness to cooperate. And much of these details would you'd be able to gather from experience and from your initial interview during the case history process. Um, the clients must be made aware that they were to indicate when they hear a tone, um, specifically for Puretone audiometry, even if it's very soft. And that might take a little bit of practice and frequent feedback. The patient's response is also an important issue. So considering the patient's age and physical dexterity, you might choose to use different patient responses like a hand raise or a button push. In some cases, you might ask the patient to say yes if they heard a tone um, or some kind of verbal response. You also need to be aware of what we call as false responses, especially when you're doing behavioral testing. Um, Most of those false responses are uh, unintentional, uh, and it could be because of poor instructions or poor understanding from the patient's part. But um, you need to look out for intentional false responses, which could be a reflection of the patient having a functional hearing loss. There's two kinds of false responses. One is a false negative response. Here, the patient does not respond, uh, even though they actually heard the tone. So the patient's response is negative, but that's false. Um, what it does to when you're trying to assess this individual is that it's going to exaggerate um, their degree of hearing loss. Another kind of false response would be like a false positive response. Here, the patient responds uh, that they heard the tone even though you weren't presenting a tone or there was no tone given. And you might see that with children who try to please you, or if they've had the wrong um, kind of notion that it's a good behavior to raise their hand or say that they heard the tone. Um, so you need to look out for both these types of false responses. So as a clinician, your role is to educate the patient regarding the test procedure. Also, depending upon the situation where you're doing this testing, the clinicians and the patient's position uh, would play an important role. In one-room settings, you might have to have the patient, um, you would have to make sure that you have the patient, that the patient does not get any visual cues from the tester or equipment. So you might have the patient, in this case, seated away from the audiometer and you might have them seated in right angles to where the equipment is. Um, in a two-room setting, lighting also again becomes important. Like in this instance, the audiologist is doing a procedure known as visual reinforcement audiometry. So here they're reinforcing the patient's turn towards the sound speaker where the sound is coming by a lighted doll box over here. So lighting is important in the sense that the patient shouldn't be able to see the tester, and getting cues from the tester regarding when the tone is being presented.